sorry for the delay, but we're all learning new things, so things happen. But thank you for joining today's session on COVID's impact on the early childhood workforce in South Carolina. Our presenters today are Megan Carolyn and Brian Burrows from Institute for Child Success. Before we get started, we have a few housekeeping items to ensure the best virtual learning experience for everyone. This session is being recorded and will be housed on our YouTube channel. You'll find a link on our website next week for anyone who is interested. There should be, we have closed captioning at the bottom of your screen. You can turn it on by clicking closed captioning and then either clicking show subtitles or view transcripts. All attendee video and microphones have been muted. If you have a question, please feel free to put it in the Q&A box. We will do our best to answer all questions today. If we're unable to do so, we will get back to you with more information as soon as possible. If you have any comments or resources you would like to share, please use the chat box for that. All handouts for this session will be provided via a link to the conference landing page. The link is available in the chat. Please remember that if you signed up to receive child care training credit and/or CEUs, you must watch this live session on the Zoom webinar in its entirety. If you have any questions, please reach out to sdit@mailbox.sc.edu. Thank you.
And Sarah, that last sentence, your microphone has gone a little out. It's coming through kind of muffled. Yeah, can't hear you yet. Though Megan, correct me if I'm wrong, and it's just my tech. But yeah, we couldn't hear anything you just said. Sorry.
I would suggest, Sarah, maybe popping it in the chat box so that folks have it for posterity. Okay. Great, and then we'll just go ahead and get started. Okay, wonderful. I'm going to turn my camera back on. Good morning, everybody. I am Megan Carolyn. I am the Director of Policy Research with the Institute for Child Success. I'll be presenting today alongside my colleague, Brian Burrows, who is the Vice President and our General Counsel at the Institute for Child Success. And there he is. For those of you who aren't familiar with ICS, we are based in Greenville, South Carolina. We are a nonprofit research and policy organization focused on improving outcomes for children prenatal to age 8. This cross-cuts a lot of different sectors, which is sort of what brought us to the conversation today. We focus on things like education, childcare, health, child welfare, and a whole lot more. Today, we're going to be discussing findings from 2 recent research projects that we've undertaken since the pandemic began in March. What we found really interesting here is that while we need to talk about the different aspects of the early childhood sector separately, childcare, education, child welfare, housing, health, we also need to talk about them together. And there has been a tendency for a very long time in the field to silo funding streams and programs, sometimes to their detriment, because there's a lot that's learned that can impact cross-sector learnings. And so what we're sharing today are findings from 2 studies that we've undertaken, supplemented a little bit with some other sources as well, on the childcare and pediatric health workforces in South Carolina. The childcare survey was undertaken pretty immediately into the COVID crisis. It was fielded in mid-May of this year. The pediatric survey was fielded more recently, and in fact, those results have not yet been published. At the end of this, we'll link you to the childcare survey and resources. The pediatric results will be coming out probably in the next 2 weeks. So you're getting a sneak peek at some data here today. We'll talk a little bit about what we found in each of those individual surveys, and then kind of cross the borders of these sectors to identify what the overarching issues are. And then I'm going to hand it over to my colleague Brian to talk a little bit about the now what, so what conversation. Now that we have this evidence, what do we do with it as an organization and from an advocacy perspective? We are hoping to have some time, again, in the Q&A box there for some discussion. Many of you are practitioners, in your own fields. We want to hear more about the challenges that you're seeing. These surveys are also now, a month to 2 months old, and it's a rapidly changing situation. When we undertook these surveys, we did not think that South Carolina's case rates of the virus would be where they are now, and that there'd be such steep challenges in reopening schools in the near future. So we're aware it's rapidly changing, and we want to keep building our own knowledge as well. So I'll just dive right in here. Like I said, 2 surveys, just a quick rundown of some key stats on them. Almost 100 respondents to our child care provider survey. Both of these were largely convenient samples. You just can't really do a randomized study of these populations. Largely the respondents to the child care survey were child care centers, which is true as well in the sector, that more child care in the state and more slots are provided by child care centers rather than family or group homes. Head Start and 4K centers were also represented here. They're in a very different situation because of the stability of state and federal funding streams. However, we wanted to get a sense of the challenges providers are facing there as well. 20 counties, so just shy of half of the counties in the state responded. And I just highlighted here the top 5 that were most present. These are all counties that have sort of larger population size, larger population density. So we actually also released a spin-off report just looking at what we deemed rural counties with lower population density, because we know that those challenges can be different. The pediatrician survey was a little bit smaller. It had 69 respondents, which is about 7% of all pediatric providers statewide. As you can see with the practice types, and we did this survey in collaboration with the South Carolina chapter of the American Academy of Pediatrics, who helped us with some of the medical language here. Academic affiliated small independent practices, which we deemed as fewer than 7 providers, and large independent practices were the bulk of our respondents there. Again, you can see the counties that were represented here. A lot of responses from Greenville County, not particularly surprising since there is such a large healthcare infrastructure there. However, we do want to sort of highlight that, of course, the findings in a survey that's so specific on Greenville might not be directly applicable to everybody. So first, we'll talk about the child care sector findings. First of all, for those who haven't stepped back and looked at the big picture a little bit, COVID essentially forced a national crisis in childcare. I've been in this field a little while and cannot remember ever seeing so many headlines in major media publications. When every outlet is covering the childcare crisis, folks are finally paying attention. For those of us who have been in the field for a while, we knew this was a long time coming. Childcare has never had enough slots for everybody. It has never been affordable for all families. And of course, we know that childcare providers and staff are underpaid, often working on very thin margins with very high turnover. And so this crisis is really where the rubber met the road. So these were all headlines as we developed our survey. 50% could not survive a closure of 2 weeks. 1/3 could close permanently without immediate financial relief in North Carolina. Nebraska is finding that folks can't pay their mortgage and rent. And in particular for family childcare, that's really concerning because that's not mortgage or rent on their business only, that's their home because they're providing those services in home. So these were pretty dire headlines. And in fact, it's gotten worse since then. Our survey has helped to contribute to this body of literature. And I'll share a few highlights from NACI as we go because they've continued updating their survey. But frankly, things have not gotten better for the childcare sector. As I think many of us know firsthand, I myself have a 3-year-old running around the house while I do this presentation today. So I think many of us are living this reality. Okay. And like I said, the sector has just never fit the needs of families. Here are the costs in South Carolina of infant and 4-year-old care based on the setting. For a 2-parent household in South Carolina, these costs are about 13% of the median household income. And for a single earner, they're paying about 25% of their household income on childcare. So it's been untenable for a long time. And then the health concerns and the rapid economic contraction caused by COVID really just triggered a whole set of dominoes. So we'll start with the findings here of operating status. And again, this was as of April 15th. Now, the state of South Carolina did not order the closure of all childcare centers. Those decisions were left based on some local conditions and the conditions specifically of providers. But about half closed in our survey. 48% said that they were closed. Records from DSS, who took responses of emergency closures that were being put into place, it was about, I think, 51% of licensed providers by DSS had closed for at least some part of the crisis. Notably, many of them are still closed. As of last week, there were between 800 and 900 providers still on the emergency closure list. Now, that does include places like a 4K classroom in a school, which of course couldn't open on its own, right? It has to wait for the whole school to open. But what that list doesn't yet tell us is how many of those emergency closures are not reopening at all, have not yet made the determination that they will not be able to reopen their doors. And that's really the most concerning thing from our findings that we'll talk about today. At the same time that about half were closed, you can also see that 39% in this little orange bubble here are open for all registered families. This spoke in some cases, from the qualitative responses. We saw that providers were afraid that if they closed, they would never reopen. They had sunk costs anyway with rent and staff, and so they might as well keep operating for families who needed them. And then particularly in rural counties, we heard a strong concern that if I close, there's nowhere else to go. In communities with high essential worker populations, ranging from medical staff to supermarket workers, the parents had to keep going to work. And so the centers felt an obligation to keep operating. So we asked this question as of April 15th, how long could your center financially survive a closure? These results were very scary, frankly. You can see here in this sort of very unattractive brown olive color, 33% said they did not know how long their finances would hold out if they closed. That's particularly concerning. Most folks who get into childcare do so because they love children and they want to make a difference. We've known for some time that there are some back-end business issues there, some of the administrative stuff that goes on. It's just not the skill set that providers got into the business for, especially with smaller, especially family child care centers. But businesses can't make decisions about their operations without knowing more about their cash flow and about their assets. And so the fact that 1/3 didn't know is very concerning. 32% then said they could not handle any closure at all. So right there, 67%, two-thirds, 65%, essentially 2/3 of the child care centers couldn't close at all or didn't know if they would be able to reopen if they closed. So it's a lot of uncertainty. It's a lot of fear being brought in. Those are folks who have created their livelihood here and are potentially seeing it just disappear. 10% said 2 weeks, 16% said 1 month. The part I want to remind you of is that we administered this survey in April. Only 9% said they could survive several months if they closed. That's where we are now. And so we're going into a scenario where realistically, it is entirely possible that 10%, maybe 20% of some of those I don't know folks are going to be able to reopen. These are scary statistics for the business owners who are potentially losing their businesses, for their employees, for what that means for the local economy. And frankly, parents can't go back to work without safe quality childcare. So that 9% is really sort of where we are now, and that's not going to be enough. The slots simply just can't meet the demand. We wanted to know a little bit more about how operations were continuing. I mean, many centers did continue serving some degree of children or were planning to reopen, at some point at their own discretion. When we asked about revenue issues, the answer was very clear: tuition. Families can't afford to pay tuition. They're not sending their kids anymore, so they're not paying. Families want to keep paying to save their spot, but they can only afford 25%. There just wasn't enough money coming in. At the same time, there's a lot of fixed costs that go into a child care center. So we asked respondents what their biggest concerns were with expenses, and they could select more than one, and they had many. We were surprised to find that the biggest concern actually was facilities costs other than rent and mortgage. You see rent and mortgage here, it's about a 50% concern. But folks are really concerned about this other category of facilities costs, which includes HVAC, utility bills, and business insurance. We heard a lot of feedback about business insurance, that it's incredibly expensive, but they need it for the liability of working with children every day, but that those insurance policies were not going to help them cover the losses of closing partially. You can also see here between the folks here who said they've continued to pay their staff and the folks down here a little bit further who say that they've had to stop paying all of their staff. Again, in the qualitative section, we heard a lot of very sad stories. One center that had done a capital fundraising campaign to improve their building and now have had to raid that fund to even continue making payroll to keep their providers there. Folks are concerned about what happened when they reopen. The economics of childcare have always been difficult, and staff are not paid. Well, they're worth their weight in gold, frankly, but they're certainly not paid their worth. And so a lot of centers were concerned that providers would be hesitant to come back because unemployment with a $600 a week federal bonus was, paying more than they were able to pay in their centers. People were just concerned that they wouldn't have the staff necessary to reopen when the time came. You also heard a lot of concerns about staff are afraid of getting sick. Staff are afraid of bringing it home to their own children. So how are we going to have the people that we need to reopen? We asked providers to try to put a number, a rough estimate to what their losses were so far. And so from March 15th to April 15th, they estimated on average losing about $22,000 per center. And they estimated that those losses would get worse in the following month at about $31,000 per center. Again, it has been several months now. We can't say for sure whether those losses have been consistent across each month because centers could sort of reopen on their own timeline depending on local conditions. And so some may have reopened sooner. Some may have closed since then as the case numbers have gone up as well. We are hoping to do a follow-up survey at some point to try to get a handle on how things have changed. I also wanted to draw attention to this average losses by center capacity. We wanted to understand sort of some of the difference in the types of centers. So as you can see, the largest centers, the three farthest right bars here are all over 100 children as their capacity. They just had the largest losses, which I think to some degree we expect because those are just with the tuition, you have less tuition coming in. But those are also more likely to be centers that are either part of a larger system or part of a larger franchise. And so to some degree, I think we had an assumption that they might be buffered by some of those economic losses by economies of scale, and that's not the case. There's also a spike here at 70 to 79, which is actually a pretty large number of the centers in the state fall into that category. And then also down here with these sort of mid-size 20 to 39 capacity seats, these are financial losses that are potentially devastating, that you cannot come back from potentially. We did find that providers who accepted childcare vouchers were in better financial shape. Their losses were smaller. And they were just better able to even nail this down. About 40% of our respondents couldn't even estimate their economic losses so far. That's because the child care vouchers were stable throughout this. Head Start funding as well was administered as though things were normal, which gave a lot of stability to this process. We also found that losses are higher in non-rural centers, about $7,000 a month higher. Which we believe is because of capacity to some degree. I'm going to take a quick moment here before we dive into pediatric healthcare to see if we have any questions from the Q&A or the chat box specific to sort of findings of that report. We'll have more of a discussion-based sharing later in the process.
And Megan, I'm not seeing any questions in either the chat or the Q&A just yet.
Great, thanks, Brian. I cannot handle having too many pop-ups up, so I really appreciate you keeping tabs on it.
No trouble.
Great. So now we're going to talk a little bit about pediatric healthcare. And like I said, we haven't officially published these findings yet. We undertook the survey in partnership with the South Carolina chapter of the American Academy of Pediatrics. So you're seeing something new and exciting. Really, we were reading up on the other literature of what's happening in primary care for adults and children. It's basically been decimated. People are afraid to go to the doctor. People are certainly afraid to bring their kids in, even though we hear certainly earlier in the crisis as well that children weren't as impacted. There's uncertainty, and people have sort of made a decision to take stay at home seriously, which is good, but to some degree, at the expense of important visits, which might actually have an impact on child health for a while to come. So what we're going to focus on today are the findings that most directly impact providers and provider operations. The full report will have a little bit more of a focus on child health as well, but for the sake of today's conversation, we're focused on the workforce. So first of all, practices generally remained open. This survey was running from late May into early June. 68% said that they were fully open, and 32% said that they were only open for certain visits. The way that this worked is that generally telehealth has been used a lot more. Nobody had switched to exclusively telehealth. They were still maintaining a physical office, but telehealth could be used to sort of triage, to figure out, yes, you do need to come in and we can get you in at this time when it's safe, or to say, I can diagnose this over the video call, and we can put in a prescription for here, or it's nothing to worry about. So we asked providers about accommodations and adjustments that they had made to operations. And there were several key trends here, many of which were recommended by the National American Academy of Pediatrics. So for example, with scheduling, switching to well visit and sick visit times specifically each day. This was providers usually saying that well visits would be done in the morning to make sure that those were only children who, did not have anything contagious potentially. And then sick visits or telehealth would be done in the afternoon. In general, practices had lower demand, and so they were shortening their hours rather than having staff in there when there are no patients coming in. We also heard some very interesting uses of physical space. The recommendations do call for keeping separate sick and well patients, which many providers do in a pediatric waiting room in normal times as well. But a lot of providers don't have 2 waiting rooms to utilize. So what do? People got very creative. Patients could wait in the parking lot, so physically just waiting online in the parking lot or in their car. Some practices would see patients in their car if it's just, check my kid out for strep throat. That was an exam that could potentially be done while the child was in the car. They were using hallways as waiting rooms to sort of get a little bit of additional space, or having patients go immediately to the exam room instead of having a waiting room at all. This is, of course, complicated with pediatrics because they're accompanied by an adult. It's not uncommon, especially with baby well child visits, to have 2 adults accompanying that. So a lot of practices had to set rules about not bringing in more than 1 adult, which sometimes can be difficult for a family, or certainly too if you have multiple children. It became a juggling act. There were also adjustments made around personnel. So part of this had to do with the finances of staffing could just not be maintained at the previous levels. But also the goal was to minimize the staff exposure to patients who might have COVID or something else that could influence them. A lot of providers noted that they had staff members who were older or had at-risk health conditions. And so trying to make sure that they were not directly working with patients at all, whether that was, dividers at the front desk or doing all paperwork virtually. A couple of providers said that they would sort of have one provider on with the sick kids, for a week and then switch to somebody else. That way they're just concentrated who's having that exposure instead of taking turns. All which had to be done pretty rapidly to adjust to the changing climate. And like we said, and we'll talk more about telehealth when we get into the billing section, telehealth just became a lifeline in so many ways for families who couldn't get in, who were afraid to go in, for providers who tried to minimize exposure. And in particular, they said it was helpful for triaging potential COVID cases, being able to assess from afar whether they thought it was just a cold or the flu, or whether they should refer a child to a testing center. What we did learn is that overall, there has been a reduction in visits for all reasons, and particularly for immunizations. So first of all, I just want to note that these findings are based on provider report. So this is 91% of providers are saying they're seeing fewer patients for acute conditions. It is not 91% fewer visits. that would be a much more detailed evaluation, and we didn't have access to that data. So this is asking providers to sort of say, did you see this? So 91% said we're seeing fewer patients for acute conditions, which is pink eye, a cold, a stomach bug, an injury. 90% are seeing fewer for chronic conditions, asthma, juvenile diabetes, things that need, ongoing maintenance and attention. 83% were seeing fewer patients for well child visits, and 83% were seeing fewer for vaccinations, which usually go hand in hand, especially in the early years. We did ask them to try to give us a sense of how deep of a reduction these were. The responses were generally either right around a 50% reduction, sort of depending on the question. This is significant. Like I said, today we're going to mostly talk about the impact on providers and not child health itself, but there's real concerns on both of these. Clearly, if children aren't having their shots, that's a problem. If children aren't having the correct management of chronic conditions, that could spiral into something worse. For providers, of course, healthcare is a fee-for-service model in this country. And if you're not seeing patients for billable services, and there's no revenue coming in. And so it's not that children have stopped getting sick, though there have been some changes because kids haven't been in school, right? We didn't have as much of a pediatric flu season this year, which at least is a silver lining. But providers are simply just not going to, not getting the revenue in because they're not able to see those patients. I'm going to share now some pretty exciting analysis if this is your kind of thing, and particularly note that this is an analysis of DHEC data from the immunization registry system in the state, which records the administration of vaccines for children. In our survey, pediatricians felt that teens and tweens were the most likely to miss their vaccine appointments since the pandemic started. That makes sense, right? We're seeing that teen and tween bodies respond to the virus more like adults. And so you're particularly concerned about, I don't want my child, my 13-year-old risking it. It makes sense as a fear. There's a lot of ways that providers can control the risk, and vaccinations are important. So we've just run this analysis on DHEC data, and I really just want to say these are preliminary findings. There's a few data questions we're gonna kind of get a finer point on with DHEC. But right now, this is reflecting national trends. Children under the age of 2 have higher continued vaccination rates during the crisis. So this is the rate here is the percent of what was expected that's actually administered. So looking at the baselines of before the pandemic started in March in the US, how many vaccines were being given, weekly, and then estimating what should have been given in the time since then. I'll note here that with 6-year-olds and 7 to 10s, that age range, 7 to 10 in particular, doesn't have specific vaccines that are given at that time, except for the flu shot, which should be given every year. Those are generally makeup vaccines for ones that were missed, or are vaccines for children with specific medical conditions who need more frequent boosters for a particular condition. So it is a concern that that's so low, but that's a much smaller set of the population. The 3 to 5 figures here, only 45% of young kids, who are getting ready to enter school have their shots on time. First of all, 3 to 5-year-olds are germ magnets. I have one. They are really strong candidates to be transmitting some of these diseases that, they should be getting vaccinated for. And in particular, we're hearing concern from pediatricians about what happens should we get to the point of returning to school in person when children suddenly need to catch up on all of these vaccines that they need for school entry. Will providers even have enough capacity to do that? In a separate survey of primary care providers nationwide, about 10% of pediatricians said that they've had to dispose of vaccines that had expired because people aren't coming in to get them. So that's a financial double hit on those practices. They bought the vaccines, then they never got repaid for them because the patients didn't come in, but they're going to need to give them to them at some point, and now they're going to have to buy them again. So there's real concern about sort of a labor shortage in order to administer these, as well as looking ahead to the flu season and making sure that we're able to vaccinate early and often every year to make sure that there aren't flu outbreaks while we're also trying to get a handle on COVID outbreaks. Sort of winding down our discussion of pediatric practices, we wanted to get a sense of how do these providers feel. Many of the providers who responded own their practices, and so their insight was particularly fascinating. First of all, we heard a lot about difficulties still accessing PPE, personal protective equipment, which frankly is a concern that we thought would have been alleviated by the time this survey was administered in May. But at this point now, a doctor needs a face mask for every patient that they're seeing, and potentially more than one during the day. They're going through more and more exam gloves than they were even before. And so while these doctors already had sources, for medical supplies, demand is higher, they're going through more supplies, and they're paying higher prices with the demand. As more businesses are opening up in the state, this could even be harder because more businesses now are also buying up face masks and gloves and hand sanitizer for their non-medical staff. Some practices were able to sort of get supplies from other departments if they're within a hospital system or an academic affiliate. Because so many surgeries were stopped as non-essential, they had additional supplies there, but it's a real supply chain issue that's going to be a problem. And we'll talk more about how childcare is impacted too in a minute. We asked providers about the billing issues that they are facing. So interestingly, we gave them 8 choices of billing issues. The average was 2.2 issues each that they reported, which sort of surprised me because I thought it would be more extreme based on what we've been hearing anecdotally. So then we looked at a little bit of subgroup analysis. Many providers were saying they had no billing issues at all. Everything was fine from a billing perspective. Other providers were saying that they had all 8 billing issues. So this was really eye-opening in terms of it sort of being a feast or famine situation. Generally speaking, it was the smaller providers who were struggling. They didn't have as robust of a billing department to begin with. They've had to furlough their billing staff, so staff can't get in as soon. And then there's just also issues with the insurance companies themselves. So the most commonly reported billing issue here is telehealth, and the green is for private insurance, the blue is for Medicaid specifically. Providers generally felt that Medicaid had adapted quickly to the changing needs of the situation and was doing better with reimbursing for telehealth than was private insurance. If you've seen a doctor by telehealth during this crisis and sort of thought to yourself, why weren't we doing this before? This was great. The answer is insurance, that it's been sort of an insurance minefield for a long time, and providers don't want to risk conducting sessions that they can't get reimbursed for. And so we're hearing a lot of interest in continuing telehealth in a reduced version moving forward, but that insurance companies sort of have to get with the times to make sure that happens. In several parts of the state, we also heard that broadband access is just such an issue. You can't have a video telehealth session to check a child's rash. And so you might have to do a phone call with that family instead, but insurance companies don't always pay the same rate for phone versus video, and that sort of unfairly penalizes rural practices. I will say too that we heard a lot of concern, even though it's only 20% here. The most cross-cutting across all practice types was patients having lost insurance, and that has to do with the very quick economic contraction since many people's health insurance is tied to their employment. Just a lot of folks losing insurance very quickly. That's something that generally providers can help you navigate, refer your family to Medicaid or, CHIP, but if patients aren't coming in, you don't have that opportunity to do so. So I want to talk a little bit about what we heard particularly in qualitative findings and really sort of the convergence here. So you've got a child care provider on the left and a doctor on the right. And here are some of the things that were very specific to those providers. Child care providers were worried about regular supplies. Again, this was in April, so sort of height of the crisis. Folks couldn't get milk. They couldn't get the groceries that they needed. They couldn't get diapers for the children in their care. One woman tells a story about almost getting in a fight at an Aldi because another customer thought she was buying too many strawberries because she needed breakfast for the kids in her child care center. So they were facing the same challenges that we all were about getting what we needed to keep our homes and businesses stocked. They're also facing enrollment uncertainty. Even as things reopen, how many families will feel comfortable sending children back? How many families can even afford to send their child back if their economic situation is now changed? Medical providers, we heard a lot about the insurance reimbursement issue. We also heard a lot about technology. Telehealth is good, but patients don't know how to use the patient portal. Providers don't know how to use the patient portal. There's not reliable internet. We also heard too that right now a lot of folks are using some federal flexibility under a Medicaid waiver. They don't have to use HIPAA compliant software right now because that change was so sudden. So you can use Skype with your provider right now, but that's not a long-term solution, and providers don't know how to navigate that when the waiver is over. They're also concerned about the politicization of public health. We heard that we need to see more hand washing, we need to see more mask wearing, and the concern that it's unfortunately become a politicized issue in South Carolina, as in other states, that it's not necessarily everybody following the mandates that they know to work. There's a lot of shared concerns, which I think is really where this conversation is most interesting. We think about childcare providers and doctors as people answering a call, and they are. These are service professionals who are following a vocation to help children. But they are small businesses, and they've been largely overlooked in our conversations about small businesses, which have focused on stores, restaurants, and offices. We heard from both that they don't have enough of the supplies they need, from PPE to cleaning supplies. We heard from both that they felt they were overlooked in government relief efforts. Nationwide, only 25% of childcare centers, were successful in their PPP, Paycheck Protection Program applications. Some of them were turned down by criteria from the banks that weren't even the criteria for the federal program. And so again, that inability to navigate the system for small childcare providers became an issue. For medical providers, we heard hospital systems are getting, gobs and gobs of money. What about us? What about primary care providers? They're concerned about cash flow, which could lead in the fear of losing their business and closing permanently. In both surveys, we had providers say, I've done this for 20 years and I'm going to have to close shop. They're concerned about their staff, about making payroll, about helping staff get on unemployment, and about health and safety. There's stress and uncertainty for themselves, and they're worried about the children that they're not seeing right now. And just to sort of drive home where we are with the provider well-being, we asked this question only on the pediatric survey. Here we go. We asked on a scale of 1 to 10, where is your stress level right now? And when we asked about in terms of safety of the staff, pediatricians said that they were at about a 6.4, which is, above the midpoint here. On the two other questions there, financial stability of the practice and well-being of the families, they're above a 7 on average. So these are times of really acute stress for primary care providers of all kinds, for pediatrics in particular. We had some respondents say, I'm getting out of the field. We've had some respondents say, I'm going to go to a big hospital system where I don't have to worry if I can make ends meet. It's really sort of forcing a reckoning in a lot of ways with the stress level. And it's something that we've seen in childcare as well. Even before the pandemic, there's an annual turnover rate in childcare of 30%. It's high stress. It's emotional labor. You take on some of the secondary trauma of what a family is going through there. It's physically difficult labor, of course, and very low pay. And so when all of this goes back to normal, whatever normal means, without intervention, we're facing potentially 2 decimated sectors that really help protect the well-being of children, in South Carolina and beyond. And so at this point, I'm going to hand it over to Brian to talk a little bit about what we do with this information now.
Thanks, Megan. And that's a good segue in that, when you're looking at the decimated childcare sector, we're thinking about that often when we're talking about it in terms of versus February levels. But it's not lost on any of us in this session anyway, that the childcare sector was incredibly fragile and strained, especially economically in February, and has been for a long, long time. And in an economic sense, you look at this as it's sort of a classic broken market, in that we're leaving a ton of value on the table. In South Carolina alone, the child care sector, as it was pre-COVID, provided about $350 million a year in direct economic activity, but was responsible for additional $1 billion and change from the families who could engage in the economy in a different way as a result of having access to childcare. And so it's significant that this is a contraction from that. But what's also significant is we were leaving another $1 billion on the table because of families who could not afford childcare at the price points that we had in the sector as they were. So one thing, the first opportunity here is that we had societally kind of come to a stable place with that truth. The people who are engaged in the field were beating the drum about this issue. But if you didn't have a young kid, or if you weren't in the space professionally, it was easy to forget about how this sector was so valuable to society and it was so under-resourced. So one thing that we think is a potential positive here is that this is drawing a lot of attention to the needs of this market, not just coming back to where we were in February, but coming back to a stronger position where we can engage, where more families who want to engage in the workforce in a different way can, if they want to, because we can support the child care sector. So first and foremost, amplifying those voices and the experiences that we're experiencing now, and not letting that thread get lost. We're also looking to keep the research really top of our radar. This is really fast moving. So we're already presenting on data about April and May, and that data is, in COVID time, 73 years ago in some respects. So paying really close attention to what's going on, especially with regards to the COVID rate increase and back to school time. Another set of opportunities and responses, developing resources and supports and materials through groups like the AAP, through First Steps, through Palmetto Shared Services. These groups are doing their dead level best to provide quality information to families and to policymakers who need to take action on these things. I'm going to pause before we talk about advocacy support, because I see a question in the question and answer. How are part-time child care workers compensated when they have lost their stream of income due to the effects of COVID-19 shutdowns or facilities closing? Full-time workers have benefits. In terms of them being compensated when their center is closed or their hours are reduced, as a general matter, and Megan, you can correct me on this, there's a hodgepodge of sorts, and that providers are trying to respond as best they can. But there is no safety net beyond whatever a provider can do. And we've already looked at the limitations of what the provider can do. Is that a fair response there, Megan?
Yeah, we heard a lot from providers who clearly, cared about their staff at a human level, about how badly they felt about the need to make those cuts or to, temporarily pause. We heard a lot of providers in both sectors say that owners had stopped taking payments in order to try to continue making some payment to staff. They tried to put their folks in touch with resources to file for unemployment, though not everybody was eligible for unemployment. And at the time that we fielded the survey in April, that system was so backed up. I mean, every state was just hit so suddenly with those unemployment claims. We also had one provider in a rural community, interestingly, note that most of their staff members were part-time. And while they were continuing to keep their providers paid, they knew that their providers had other jobs that they had now lost. And so when you have somebody who's putting together two part-time income sources, whether out of personal preference or economic need, and 50% of those income sources disappears, they weren't eligible to file for unemployment under the part-time ones that they had lost. And so now they were just living on one income that the providers knew was insufficient. And so I think our first answer would be, as it is, as Brian said, the hodgepodge of systems is not always working for everybody. And then many of the providers are simply not eligible for those systems, in terms of unemployment for their staff. And so it's been a huge, huge hole in the safety net. I would be remiss if I didn't say, and I should have said it sooner, that childcare providers overwhelmingly in every state are overwhelmingly women of color. So these are employees who are already sort of living at the economic fringes in terms of low pay rates, and now are sort of being, you're going to see a real domino effect. Many of them are parents themselves. It's a real concern for the hit on the local economy as well as for those individual families.
And I'll also add, while full-time workers do receive some unemployment benefits from state and federal sources, a lot of those have now hit pause. But also, I want to be clear, full-time workers in the child care sector, at least, very often do not receive what many folks think of as benefits. So oftentimes these salaries come without paid sick or insurance or that sort of thing. So there's a, how can we access positivity rates at county or school district level? And Christy, let's see, this question, Megan, do you have thoughts on this question?
Sorry, I kept unmuting and remuting myself. I'm thinking that this is a question specifically about viewing case rates, the COVID positivity rates.
That's my assumption also.
Okay. To my knowledge, okay, she says yes. Excellent. We're on the right track. To my knowledge, you cannot get those at the school district level right now. I do not know what the state's plan is with releasing that information. It's been sort of a hot button in the field about if a child care center or a school has an outbreak, how much information has to be released for the sake of public health and how much risks the health privacy of minors. So I'm not 100% sure about that. I do know that DHEC's dashboard is pretty good at the county level. And then that information has also been aggregated by the New York Times for a national database that they're using, which I find helpful because then you can compare it to other counties in other states as well. But to my knowledge, I believe DHEC has the information on age breakdowns to some degree, age groups. I haven't looked at it in a little while though. But DHEC does have a data dashboard with some degree of that information.
Thanks, Megan. So turning real briefly, feel free to ask any additional questions and we'll turn to them. The next slide is discussion anyway. So, but as you probably inferred, very much of what we've been talking about has been, money stuff. This is the economic strain. It's all about cash flow and capital to providers. And so advocacy supports are really critical. And, one of the things I like to share with folks who are looking at advocacy issues is that most policymakers are wanting to do the right thing, and very often on any given topic have no idea what that is. Very few lawmakers are former child care providers. Some of them have had young children, some of them have not, but they certainly don't necessarily have the lived experience of the folks in the session, for instance. And so they tend to respond to that type of challenge where they don't know what the right thing is to do through a couple of things. One is listening to experts, and one is listening to constituents who have lived expertise. And so many of you on this session are both. You are both an expert and you have lived experience with it and are constituents. And so it can be incredibly powerful to just call a legislative office and say, this is what I have experienced. And, I was hearing from a provider who called up her state senator and said, I inherited this child care center from my mom who started it, and we've run it for the last 30 years, and we're closing permanently because of a variety of issues, some of them COVID related and some of them state regulatory. And so that can be incredibly powerful. And it's also very timely because people are starting to notice that this is not just about, oh, we like little kids, which we do, and we want their brains to grow in a robust and strong way, which we do. But it's also immediately going to affect the GDP today. There was a Washington Post story about recently about how if the estimates are right that we're going to lose about half of the child care supply, that's an 8.4% hit on the national economy just from families who can no longer return to work and who want to return to work. Calling those legislators, there are a lot of things going on right now with both federal and state money. For instance, the state has received CARES money for $63 million. They've distributed a significant portion of that. They still have, from my best understanding, they still have a significant amount that's available there. The state also received a $40 million bump in Child Care Development Block Grant money in 2018, and that additional $40 million has come every year since. It has not yet deployed that towards childcare. And then at the federal level, it's interesting when you follow federal policy, the House passed a bill that would provide an additional $7 billion nationally, which would equate to roughly 160 million maybe for South Carolina, which is a very significant component for that sector. Then the Senate passed one that would provide 15 billion, and then the House, not to be undone, passed one that would provide 60 million. And so we're not sure where they're going to settle, but as somebody who's been working on trying to get resources for childcare, I love that they're trying to one up each other. And I hope that continues until we get more robust investment. But all of that can only be bolstered by folks talking to their legislators and policymakers. We have one last question, and we have one more minute. So Megan, maybe we should go ahead and advance to the resources slide while we tackle this last question. Do you have any data as it relates to the effect of special education services, speech therapy, OTPT, for children with disabilities? And for that, as in many things, I'm looking at our data oracle, which is Megan.
Data?
Yeah.
We don't have data. What we do have is an overwhelming sense of dread and concern. If I may risk being hyperbolic for a moment. It would be, it's difficult
and Jenny
to measure.
Also, Jenny may also have some thoughts here too, but keep going, Megan.
It's very hard to get those data because for children under the age of 3 versus children who are school age, it's difficult to, those two different systems that are working there. And so it's difficult to collect those data, but certainly news and district reports all suggest that it has been difficult to connect. It's also difficult to move these services to meaningful digital engagement. Speech therapy, in particular, we are reading stories about the parents trying to help with the facial movements to mimic the movements on the screen. It's something to be concerned about for returning as well. I personally, not saying this is an organizational position, but I personally am a strong advocate for communicator masks, which have the clear window panels for young children, for all children, but in particular because children learn language from seeing mouths and they learn facial expressions. For some kids with autism who have sort of relied on some face reading cues, for some kids with speech therapy who really need to see the mouths moving, those masks can make a big difference. There isn't clinical data to suggest it yet, but there's a very strong theory of change. So it's something that I think we're going to hear more about as the school year starts, but there isn't great data on yet.
And Jenny, did you want to add anything to that?
Sure. Thanks for letting me, even though I am a facilitator, but in terms of supports for distance special education services to be offered, we have a website at the Department of Ed on the Office of Special Education Services page that includes both early childhood and older students, information on best practice, how to support families, and things of that nature. We also have, and it is coming out, I believe, either this week or early next week, guidance for school districts on how to offer distant special education models, and in a variety of scenarios, which would include what does free appropriate public education look like when the early childhood environment is distance and things of that nature. So there are a lot of resources, and if we can do it, if you'd like, I can see if we can put links to those when this is posted on the YouTube channel. There's also information on distance child find modalities and distance evaluation
those sorts of things. So, so there's more information on that, but it is, but Megan is exactly right. There's a lot of fear that as you transition from one environment to the other, being face-to-face versus distance, that something might get lost. And also the demands on parents are more than they ever have been before. I say that as an opinion as a parent. So, so how to support,
I echo that as an opinion as a parent.
So how to support is a challenge. But thanks.
Yeah, and lucky that you are our facilitator with that robust information. Thank you.
Indeed.
Great. I think that concludes our prepared presentation. Jenny, Sarah, should I go to the last slide at this point?
Yes, please.
Okay, here we go.
Cool.
Okay, thank you. If you have any questions or would like to provide additional feedback, please feel free to email us at scic@mailbox.sc.edu. You can find information about champions and access the recorded sessions and handouts at scinclusion.org. Thank you to everybody who participated today. Special thanks to our co-host, Jenny May, and our presenters and our captioner. Thank you for bearing with us as we had our technical difficulties. We're all learning new things, and we hope you had a great experience. I am going to launch the evaluation via poll. Please take a moment to complete it, and then I'll wait, and then I will tell you more. Excellent. I see them rolling in. Okay. If you are joining by phone only and are seeking childcare training credit or CEU credit, please send an email to scic@mailbox.sc.edu. That includes your name, the name of the session, and your phone number that you are using to join the session. That's the way we're going to ensure that everybody gets the credit that they earned. I'm going to put this instruction in the chat. And please feel free to copy that for your records later on. Okay, we're at 95%, 96. And I'm going to stay on for the last 2% to complete, but thank you to our panelists and our captioner. If you need to hop off, that is fine. Oh, we're at 100%.
Yay.
Thanks, everybody.
Yes, thank you. Thank you, thank you.
This is the part of a conference where we all go out to the lobby and crowd around to get lunch now, right?
Typically.
Great.
Thanks everybody for giving us the chance to chat today.
Thank you. Bye.